patients often have to travel great distances. I know this from my experience as a medical oncologist.
Because we are an integrated system and because we're so rural, we have patients coming from sometimes 300 and 400 miles away.
Our oncologists became very concerned about smokers in the community who weren't being appropriately monitored or treated. We knew we needed partnerships with radiology, oncology, pulmonary medicine, and pathology, but it wasn't until we had a series of meetings that we realized just what kind of contributions each needed to make.
When I first heard about this program, I was happy about it because it was another form of help for me to offer comprehensive care to my patients.
We primarily coordinated through pulmonary medicine. First and foremost, we wanted to make sure with what we were recommending actually dovetailed with what they were doing and what they wanted to do for patient management.
Because we were doing the CT heart screenings at the same time, we were able to utilize the same spot. So the patients were able to go over to the same area where we were doing the CT heart screenings, and we could utilize the same space.
We realized once we started the process that we were treating people that hadn't been seen. We were finding cancers earlier that could be treatable.
So whenever you find a lung nodule and you have a lung nodule program, you want to make sure that every single patient who has a lung nodule identified gets the appropriate follow-up.
We worked through the nurse navigators to make sure that they sent the appropriate recommendations to family practice or internal medicine or outside caregivers about what was expected next. And they were the ones that made sure that the order came in and that the patient showed up for the appointments.
As a lung cancer and nodule nurse navigator, I have two roles. Our first role is the lung nodule program. This is where we see any patients, they're put into our surveillance program from their primary care physician, sent to us, and then we follow their nodules along with their primary care physician. The other part of my role is to take care of any lung cancer patients when they're first diagnosed, all the way through till they start treatment.
What was key for our success was having the buy-in and acceptance of our referring providers. We had a lot of referring providers from small communities, tiny clinics, towns that we drive to perhaps once or twice a month. And they didn't know what we were up to or why we were doing this. They had very close relationships with their patients and they didn't want us interfering. What we explained to them is we're not interfering, but you're part of a bigger health system and let us help you help these patients.
We've worked increasingly with our radiologists. We have a lung cancer oversight committee in our cancer center that includes the medical oncologists, the pulmonologists, radiologists, interventional radiologists, and other staff. Working together is really what got the program off the ground.
Since we came up with kind of a standardized set of protocols and we started working together at the screening center and the lung nodule clinic, together with the ordering providers in pulmonology, we have a lot of checks and balances to kind of make sure that these patients don't get missed and don't fall through the cracks.
It is like a closed loop where the information comes back to me after the evaluation. So that is very helpful and is in the best interest of the patient.
Other places can do this too. They don't need to have high-level experts to make this work. They just need to have people who are engaged and passionate about caring for patients.